So I think I'm going to wait until my slide. Oh, wonderful. Wonderful. So Kevin and Kathleen, thank you. That was incredibly educational, at least on my end. I can say that my posture is going to, like I have to be mindful of what my posture looks like right now. I can tell you as a patient and as a clinician, I'm incredibly thrilled to be at this event of such caliber and importance. And I was very happy when I heard that it's going to be taking place in my home state, Arizona. So I just came strictly from work and joined you guys. My name, again, is Adrijana Kekic. I am a pharmacogenomics clinical pharmacy specialist. This is a mouthful to say that I'm a pharmacist trained in genetics. And I work at the Mayo Clinic in Arizona. A lot of my patients are referred to our pharmacogenomics or individualized medicine clinic because of the medication issues. So I'm going to talk to you a little bit about that today in the context of HEDS. Nothing to disclose. My hope that at the end of my talk today, you will walk away with a couple of things. Appreciation of how genetic variations can contribute to how we respond to medications, because that does differ. And secondly, I'm going to talk to you a little bit about what we do in the clinic and how pharmacogenomic testing can be used. What are some of the opportunities or maybe barriers, especially when it comes to HEDS patients. So HEDS, as we know, is the most common of the hereditary disorders in the connective tissue family. And clinical description really can be eclectic. I see a lot of, predominantly, obviously, patients who are female, or those at least who identify female at the, or assigned female as at the date of birth, at the time of birth. And in addition, a lot of these people suffer from a variety of different conditions. So headaches, fibromyalgia, chronic pain, perhaps mood disorders, and cardiovascular issues, and so on. But one other thing that really stands out, like Kathleen already pointed out, a lot of patients that I see with HEDS diagnosis are also intolerant to medications, or perhaps do not experience full benefit with medications prescribed. So I want to introduce you to a patient that I saw a little over a year ago. I'm going to call her Debbie. This is not her name. But unfortunately for Debbie, she has a complex medical history, conditions that I mentioned, and also complex pharmacy history. She's on many medications. What stands out with Debbie is that she's quite representative of patients with HEDS who I see in the clinic. So, as I mentioned, complex medication history, or current medication at least list, is rather extensive, and it's reflective of those conditions that I mentioned. So fluoxetine for mood, ibuprofen for aches and pains, melatonin she takes to help kind of fall asleep, magnesium similarly to help with relaxation and sleep, metoprolol she's been taking for some cardiovascular issues, primarily increased or tachycardia, increased heart rate, Prilosec because of GERD, acid reflux, and tramadol she's been taking on and off to help with pain. As you see, each of the medications that I list here has, or most of them rather, have some issue that Debbie has identified, including tramadol really not being helpful for pain, fluoxetine, she's not really sure if it works, and metoprolol has caused some bradycardia, really lowered heart rate than we would want it to be. So, of course, prior to seeing patients in a clinic, provider usually will let me know that they're referring a patient, and in this case, same was done. Her physician, primary care physician, thought it would be a good idea to pursue pharmacogenomic testing because Debbie has trialed many medications and had either side effects to them, or like in a case of lidocaine, which she used for dental procedures typically, she said that she needed megadoses. She needed she said, horse doses of lidocaine to even experience numbing. So therefore, pharmacogenomic testing was ordered. The results came back, and this is what the results look like. So when you look at these results, there is obviously nothing intuitive about them. I mean, I can kind of break them down for a little bit here. There are 3 columns here that you can see. Column on the left are genes that are tested. We typically test upwards of about 30 genes. It depends on the test that you use. Everything here is, for the most part, listed alphabetically. It doesn't start with letter A, starts with the letter C, CYP, 1A2, CYP, 2B6. This CYP family of genes is important because they give instructions to us humans to make drug metabolizing enzymes, and they're called the same name. Like, for example, CYP1A2 gives instructions to make drug metabolizing enzyme CYP1A2. So without going further into this, second column here is called the genotype. Genotype is essentially an arbitrary system of letters and numbers to say what sort of mutation, if any, did you get from your parents. Phenotype, luckily, is a little bit more instructive. So you can say, am I a normal metabolizer, poor metabolizer, something along that line. It's a little bit more descriptive. I'm going to come back to Debbie's results, but I want to point out, and it's very difficult to see here, I just see that now. Of the upwards of 30 genes that we tested, she had several mutations, which is not unusual. When I meet with patients who do not have HEDS, many of them have mutations without realizing that they have them. But for Debbie, she had several that were also of significant clinical impact, and I'll explain what I mean with that. So Debbie, when I saw her, this was about a year and a half ago, we were heavily into COVID. I could not see her face to face. This was the first time that Debbie used telehealth type of a consult. And even through the screen, I could see how anxious she was. So Debbie told me, I acknowledge that this is complex, and when you look at these results, they don't really mean anything. They're not really patient-facing, which is why patients typically meet with us, so we can make some sense and give them and providers, physicians, direction. So after Debbie learned that I also have symptoms of HEDS, although I have never really been fully diagnosed, she visibly kind of relaxed. And she said, I have to be honest, prior to meeting with you, I did get a message on my patient portal. I saw those results. I tried to look them up. I tried to Google them, but none of this makes sense. What exactly is this PGX, and what can it do to help me? So let's actually start there. What exactly is this PGX thing? PGX is a tool that we use within this term that we call precision medicine or personalized medicine. Simply speaking, pharmacogenomics studies how your genetics, my genetics, influences the way that we metabolize medications and respond to drugs. So your genetics actually can dictate that. So the goal of pharmacogenomics is to use this genetic knowledge in addition to other, let's say, patient-specific factors, sex, like liver function, renal function, presence of other medications, use that in conjunction to say what might be a better therapy for you based on these factors, including the genetics. So why is that important? Why did our institution and many others invested put rather significant investments and education behind implementing pharmacogenomics in our clinical practice? The reason for that, I think, is a very intuitive one. You may be even personally or intimately familiar with it, and that is that one size does not fit all. We actually have a problem in the United States and globally with drugs, and specifically with drug safety and drug efficacy. So this little pictorial here, iconographic here that I'm showing you, I want to point out to the fact that even commonly used medications, even when prescribed correctly, may not work. So this here is really a visual representation of data that came from a study, landmark study done by Spears and his group, essentially showing that 4 out of 10 patients will not have proper response to common medications like antidepressants, medications for diabetes, and so on. As you go down this list, ineffectiveness increases, especially with medications that are used for like Alzheimer's disease, not surprisingly, and cancer medications as well. So in addition to understanding that one size does not fit all, we also know that genetics, or drug use, I should say, prescription medications as well, are associated with safety issues, with toxicity. You may be surprised when I tell you that the 4th leading cause of death in this country is linked to drug use, prescription drug use, adverse drug events. And so we actually leverage this combined science of pharmacology, study of drugs, and genetics to say, can we identify patients who actually might be at this increased risk of drug toxicity, which I'm highlighting here in red, and also those patients who might be at the increased risk of simply not responding to a medication, which we're highlighting here in yellow. So that's what that's where the hope really is, and that's what we're hoping and trying to do in our clinic even today. So you may say, well, Adriana, okay, that's great. I understand that genetics may play a role, but there are many other factors. It's not all about genetics. And I would say you're absolutely correct. We're talking about the clinical tool right now, this pharmacogenomics, but I gotta tell you, the rate of medical knowledge is doubling every 73 days. Every 73 days, it's doubling, which essentially I'm trying to say is we will continue to learn more how genetics and other patient-specific factors drive not only health, illnesses, but also therapy response. So what I'm really trying to kind of illustrate with this little slide here is to say that beyond genetics, we need to make sure that we include other patient-specific factors because, genetics is not the end-all be-all. So this field is moving into something that you may hear in future called multi-omics. This is just one of the tools that we use in our practice right now. We have built, so Mayo Clinic Center for Individualized Medicine and University of Illinois has built this predictive tool, an algorithm that we use, that we can use in patients with major depressive disorder. This is a highly heterogeneous disease, which means it presents in many different ways. And what we found is that when we leverage both clinical biomarkers, meaning how you may present, what you feel, with genetic biomarkers, we actually can better predict how a patient will respond to the first-line therapy, which is an SSRI, selective serotonin reuptake inhibitor, kind of like that fluoxetine that Debbie is taking. We can increase the prediction from about 50% to almost 80%. So what I want to talk about next, is for those of you who are clinicians, you may say, well, that's great, but this might be expensive. Where's the clinical utilities? Maybe still not certain. Here's what I can say. Right now, pharmacogenomic testing can be used in clinical practice with medications who have very specific PGX or genetic guidelines, meaning medications that can cause hypersensitivity reactions like skin sloughing off. I'm listing some of them here. Also medications where we have genetic biomarkers to say, you know what, you might be at increased risk of actually dying from codeine if we give it to you, or you may not respond to tramadol or PPIs or SSRIs. PPIs are things like omeprazole given for GERD. So we already have guidance with these medications to implement it and really help our clinicians and our patients figure out what might be a better choice for them. Here is where I see most of the referrals in our PGX clinic. It's the patients who have general eclectic list of drug issues. So polypharmacy, meaning more than 5 medications that they take, medication therapy failure, and medication intolerance. So I want to really briefly outline the clinical workflow for those of you who are thinking, well, how do I do this if I wanted to do this in my clinical practice? Patient is identified as a candidate for PGX testing based on what I just said. Order is typically placed, at least in our institution, by a pharmacist or a physician, and patient can be swabbed or blood work can be done, either or. And at the same time, consult with a PGX-trained pharmacist is ordered. Then consult, I meet with the patient, or a pharmacist like myself meets with the patient. We go through the medication therapy management, all of the elements of it. And then we provide some assessment and guidance that is shared not only with the referring physician, but rather with the patient as well, because this is a lot to digest. It's incredibly overwhelming coming into these visits. And then most important part of this whole workflow is the fact that once you had the pharmacogenomic testing, those results are placed in the patient portal into so-called electronic health record. Why is this important? It's important because anytime any physician within that institution, or at least our institution, is prescribing a medication that is significantly affected by genetics, they will automatically be stopped, and then guidance is given to them to say what to do. Okay? And of course, we need to consider cost and limitations. I can tell you, I've been doing this for several years with implementing this in a clinical practice and doing it in a clinical practice. The cost continues to drop down, and the number of gene and genetic variants that we test for continues to rise, as well as the evidence behind them. The problem is we don't have a whole lot of evidence in patients who have EDS or HEDS. So I want to go back really briefly to Debbie's test results. Out of this whole spiel of the results that you see, the genes and everything you see, I'm going to point out one. She has more than one mutation, but this is the most significant thing for her.
Hi, I'm Dr. Jordan Tischler. I am a...
Hi, Jordan. So, CYP2D6, what about this CYP2D6? CYP2D6 is a gene that's highly heterogeneous, very polymorphic, meaning if I look at the number of us in the room, half of the room or less is going to have normal capacity to metabolize through that pathway. The other half, myself included, will not, which means the medications that need to be metabolized through that pathway will be significantly affected. So you could be at increased risk of side effects or lack of efficacy depending on the medication. For Debbie, interestingly, she indeed was so-called poor to intermediate metabolizer. When I meet with patients, I typically will tell them normal metabolizer. Think about these genes almost as individual roads that medications need to travel through. Normal road, you should have 2 lanes in it. You get 1 lane from your mom, you get the other lane from your dad. Debbie did not get that. Debbie has 1 road that doesn't exist, 1 lane of the road that doesn't exist. The other lane of that road has multiple roadblocks on it, which essentially means that she will not be, genetically speaking, nothing else taken in consideration, she will not be able to properly metabolize almost 1/4 of medications that need to go through that pathway. In addition to drug metabolizing enzymes, we also look to see how these drug targets or drug receptors are also expressed, but we have very little guidance there. The firm guidance is behind CYP2D6 and something like CYP2C19. Luckily for Debbie, she's a mostly normal metabolizer there. So what's the clinical impact behind this? The clinical impact, and I already explained this, that this is a highly polymorphic gene, so we need to be careful not to make an assumption that you're a normal metabolizer. As a matter of fact, that's what I was trying to highlight here, that most of us will not be. Most of us will fall onto non-normal metabolism. So what does this mean for Debbie? We actually had to change her medications. So, as I said, she had several genes that we identified with mutations. But just using that CYP2D6 gene and knowledge about it, we made these recommendations. Change metoprolol. Why? Because metoprolol is extensively metabolized through CYP2D6. What does that mean? It can accumulate. What happens when beta blocker accumulates? You start experiencing fatigue and drop in heart rate. That's exactly what was going on. Change tramadol to something like duloxetine, which she hasn't trialed. We don't know if it's going to be honestly effective. That's a whole other conversation. But tramadol, she cannot properly convert into active medication. Change fluoxetine to something that's not going to be affected by CYP2D6. What about folic acid and MTHFR? She's also deficient in this enzyme, which converts folic acid into folate. We recommended that she no longer takes folic acid, but rather folate supplement. I have only 20 seconds left. I'm so proud of myself because I always go over on time. Actually, I will go over on time this time as well. But what I want to maybe just open a little door or a window to, there is a lot that we don't know. There is hope that I see pharmacogenomic testing, genomic testing, this multi-omics that I talked about can bring into the conversation. That's what I wanted to point out. I also want to point out that most of the clinical testing done nowadays is genotyping, not sequencing. My hope is that we're going to be doing sequencing in future. What does that mean? Genotyping, we're looking for already known predominant common variants. Sequencing is looking for all of the genes and genetic variants or mutations that that person may have. And we yet are to learn what is happening within EDS and HEDS. Here's what I want maybe to emphasize, to kind of for us to walk away with. One size does not fit all when it comes to drugs. I think this is an intuitive knowledge. We know genetics plays a role. We can use pharmacogenomics to identify some of those patients who might be affected. We know that in future we're going to be incorporating other clinical factors. There are many drugs that have PGX guidelines, so this can be implemented in clinical practice. And finally, the point I want to make is we need to be thinking, how do we personalize therapy if drugs need to be used? And right now, the best that we can do clinically is leverage genetics with other clinical biomarkers. With that, I want to thank you, and I want to thank you for being patient with me going over time.